Investigation protocols in pituitary adenomas, functional and non-functional. Introduction: pituitary gland, pituitary fossa, mass, 5 grams. Dimensions: 7 mm, height 9 mm, AP 11 meters transverse. Originates from Rathke's pouch and infundibulum. Cell type: hormone. Clinical syndrome. Tumor type: somatotroph. Growth hormone: acromeg/gigan. Sparsely granulated GH cell. Densely granulated GH cell. Lactotroph. Prolactin. Amin/galactor. Sparsely granulated PRL. Densely granulated PRL. Somato/lact. GH plus PRL. Acro plus hyperprol. Mixed GH/PRL. Mammo plus somato. Amin/gal/acro. Acido plus stem cell. Corticotroph. ACTH/POMC/BLPH/MSH. Cushing's, Nelson. Densely granulated ACTH. Sparsely granulated ACTH. Gonadotroph. FSH, LH, I subunit. Hypopituitarism. Thyrotroph. TSH, A subunit. Hypothyroid/hypopituitarism. Null cell. None. Null cell. Oncocytoma. Introduction: 15% of intracranial tumors present as incidental finding in 5 to 20%. Broadly divided: A. Functional. B. Non-functional. Investigation protocol. History and physical examination. Neuro-ophthalmology. Acuity, field, fundus and movements. Hormone levels, basal hormone and dynamic testing. Aim: hypersecretory state or insufficiency. Radiology: A. X-rays. B. MRI. C. NCCT/CACT. Routine blood investigation. Presentation: mass effect hypersecretion/hyposecretion. Incidental finding. Apoplexy, complete history and physical examination. Eyes, visual acuity, visual field, fundoscopy. Neck: thyroid, carotid brute. Chest: gynecomastia, galactorrhea. Abdomen: striae, obesity. Extremities: edema, enlargement. Skin pigment, hair, bruises. Mass effect: visual disturbances. Visual field defect, usually very insidious and slowly progressive. Diplopia. Visual acuity. Hydrocephalus. Headache. Cranial nerve palsies. Raised intracranial pressure, acute presentation secondary to tumor. Apoplexy. Acute presentation secondary to tumor. Hemorrhagic necrosis. Headache. Vomiting. Blindness. Ocular paresis. Altered level of consciousness. Prolactin. Galactorrhea, amenorrhea, osteoporosis. GH. Acromegaly, organomegaly, DM. ACTH. Cushing's disease, diabetes mellitus, osteoporosis, obesity, hypertension. TSH. Hyperthyroidism, cardiac dysrhythmia, heat intolerance. Radiology: X-rays, widening of cell, destruction of cellar floor. Relation of median sphenoidal septum. Aeration of sphenoid sinus conchyle. Sclerotic. Mixed. NCCT plus CACT head/cella with thin coronal cuts. Findings as seen in X-rays. Isodense to adjacent brain parenchyma. Intense contrast enhancement. Calcifications uncommon, less than 5%. Apoplexy: hyperdensity. Pituitary adenoma classified based on size, microadenoma less than 10 mm. MRI brain. Sagittal T. Y and coronal T1Y cellar and paracellar region with / without contrast 2.5 mm thin contiguous slices and 5 mm slices axial T2Y of whole brain. Normal pituitary is iso-intense to gray matter on T1Y with contrast enhancing. Pituitary adenoma classified based on size. Microadenoma less than 10 mm. Macroadenoma greater than 10 mm. Giant pit adenoma greater than 40 mm. Macroadenoma, they are hypo to iso-intense to gray matter on T1Y, contrast enhancing. Microadenomas dynamic contrast study done by 5T1Y turbo spin 3 mm thin slices repetitively at 20, 40, 60. 80,100 seconds after 10 ml contrast injection at 2 ml per second. Microadenoma enhance and wash out quickly as compared to normal gland post-contrast and hence appear hypointense. Deviation of stalk. Bulging of inferior and superior margin. Normal gland. Signal intensity. Adenoma. T0. Texas. Time. Hardy classification pituitary adenoma. Grade 0 size less than 10 mm, cella normal. Grade 1 size less than 10 mm, cella expanded. Grade 2 size greater than 10 mm, cella expanded. Grade 3 size greater than 10 mm, focal destruction. Grade 4 size greater than 10 mm, diffuse destruction. Grade 5 distant spread. Based on extension supracellar paracellar D intracranial, intradural. 0 none. A supracellar cistern. B antrecess of third ventricle obliterated. C4 of third ventricle grossly displaced. Paracellar. D intracranial, intradural. E into or beneath the cavernous sinus. Screening studies for pituitary lesion. Hormone excess. Serum prolactin. Serum IGF-1. Serum LH, FSH. Serum A subunit. Serum TSH. Urinary 24-hour cortisol. Hormone deficiency. Serum cortisol. Serum T4, free T3. Serum testosterone, men. Serum estradiol, women. Dynamic test to identify pituitary hypersecretion. Dynamic stimulation/suppression testing may be useful in select cases to further evaluate pituitary reserve and/or for pituitary hyperfunction. Acromegaly. Oral glucose test. Cushing's syndrome/disease, a low-dose dexamethasone. B low-dose dexamethasone plus CRH. C high-dose dexamethasone. D inferior pederis sampling plus CRH. Dynamic test to identify pituitary deficiency. ACT, low-dose ACT by giving 1 microgram 4-S cortisol after 30 minutes less than 18 micrograms/DL identifies central adrenal deficiency. Prolactinoma 30 to 50% of endocrine active tumors clinical features. Amenorrhea infertility, loss of libido, oligospermia. Galactorrhea in 80% females and 30% men. Majority are microadenomas. 30% of them in women are self-limiting. Prolactinoma prolactin less than 25 nanograms/ml normal. 25-115 nanograms/ml prolactinoma, stalk effect, drugs, hypothyroid. Greater than 115 nanograms/ml prolactinoma. Hook effect. Even large elevations will show normal PRL levels on testing due to large size of molecules. Do serial dilutions. Not all hyperprolactinemia is due to a prolactinoma. Causes of hyperprolactinemia. Medications psychotropic, for example, haloperidol, risperidone, antidepressants, for example, amoxicillin, estrogen opiates, calcium channel blocker, verapamil, antihypertensives, amethyldopa, reserpine, dopamine antagonists, domperidone, metoclopramide, pituitary adenoma, prolactin secreting adenoma, GH secreting adenoma, secondary hyperprolactinemia, usually a macroadenoma, other pituitary lesion, for example, in metastatic, sarcoid, aneurysm, hypothalamic lesion, head trauma, pregnancy, spinal cord lesions, chest wall trauma, nipple stimulation, Cushing's disease. 15% of all pituitary adenomas in adults. 90% microadenomas. Common in women. 55% pit adenoma in children. Clinical features: central obesity, purple striae, hypertension, diabetes, ecchymosis, poor wound healing, lipid abnormalities, neuropsychiatric problems. Cushing's disease. Best screening test: 24 hours UFC level 95 to 100% sensitivity, 400 micrograms/day of UFC is diagnostic. Midnight plasma cortisol of 5.2 micrograms/dl is diagnostic of Cushing's. Low-dose dexamethasone test: 1 mg of dexa at 11 a.m. and measurement of cortisol at 8 a.m. Less than 5 micrograms/dl normal. 5 to 10 micrograms/dl equivocal. Greater than 10 micrograms diagnostic. Plasma corticotropin level greater than 20 pg/ml diagnostic. Greater than 10 pg/ml suggestive. Less than 5 pg/ml corticotroph. Independent. Cushing's disease. High-dose DEXA suppression test: if corticotrophs greater than 10 pg/ml. 2 mg of DEXA given every 6 hourly for 2 days, if greater than 69% fall in 24 hours. UFC, pre and post DEXA, is 100% specific for CD. 8 mg dexamethasone test: -8 mg dexamethasone is given at 11 p.m. and drop in greater than 50% cortisol indicates CD. Corticotropin releasing hormone stimulation test: IMAGI/kgcrh4 in morning, if increases greater than 35% corticotropin level at 15-30 minutes above baseline yields 100% specificity and 93% sensitivity for CD. Cushing's disease inferior petrosal sinus sampling. Classical clinical and biochemical CD features with MRI. Negative patient. Equivocal suppression and stimulation test. Diagnostic accuracy is 80 to 100%. Blood samples are obtained at basal and 3,5-10 minutes after CRH administration and IPS/PS ratio calculated. IPS/PS greater than 3 CD. IPS/PS less than 2 ectopic. Rarely 2 to 3 ectopic. IPS gradient helps in lateralization of adenoma. Cushing's syndrome. Cushing's syndrome. Acromegaly, fourth decade of life, 10.7 years. Constitute 20% of all pituitary tumors. Preoperation 10 years to diagnosis in adults and 3.1 years in children. Plurihormonal. Acromegaly, prepuberty, gigantism and precocious puberty. Pubescent amenorrhea, hypogonadism. Adult skeletal and soft tissue overgrowth and deformities, cardiac, neuromuscular, respiratory, endocrine, metabolic complications and neoplastic transformation. Random GH, not useful, gives false positive and false negative results. Insulin-like growth factor 1, IGF-1, best for screening, represents average daily GH secretion. Oral glucose GH suppression testing, gold standard to confirm diagnosis. 75 mg of glucose load normally suppresses GH greater than 2 nanograms/ml Rhea. GH nadir greater than 2 nanograms/ml Rhea with adenoma confirms it. GHRH stimulation test, acromegaly chest and abdomen imaging for ectopic GHRH secreting tumors. Empty cella shows pituitary infarction. Scintigraphy. Ancillary tests. Blood glucose, urine, cardiac and respiratory screening for colorectal neoplasia. Clinically acromegaly, MRI pit adenoma, GH 5 nanograms/ml if GH less than 5 nanograms/ml. IGF-1, elevated. If no, oral glucose suppression test confirms it. Rarely MRI negative. Measure GHRH levels, ectopit/chest. Thyrotrophadenoma TSH secreting tumors 1 to 2% of pit adenomas. Mixed hormonal secretion -30%. GH, PRL, gonadotropins. 90% macroadenomas. Mean duration PT 9 years. Clinical features of goiter, warm skin, heat intolerance, cardiac arrhythmias and other hypothyroid features. Thyrotrophadenoma lab investigations TSH, free T4, to be direct method. I subunit, PRL, GH, SHB. Iodine scan USG of thyroid. Dynamic testing with TRH. TSH normal, A subunit/TSH ratio. Clinical suspicion, MRI pit adenoma, baseline TSH, free T4/T3, A subunit, PRL, GH. TSH normal, A subunit/TSH ratio. Less than 5.7 in normogonads, less than 29.1 in hypergonad. TSH elevated less than 0.7 in normogonads. Less than 1.0 in hypergonads. MRI equivocal, DRH stimulation test. Gonadotropinomas 7 to 15% of pit adenomas. 40 to 50% macroadenomas secrete gonadotropins. Clinical features of mass effect, visual symptoms, hypogonadism, amenorrhea, hypothyroid, hypercortisolism, gonadotropinomas lab investigations basal hormonal levels. DRH stimulated gonadotropins, and subunits. Normally causes absent FSH response and no more than 33% increase in LH and BLH. Primary hypogonadism LH, FSH elevated and don't respond to TRH. Gonadotropinomas have greater than 60% increase in BLH levels. Multidisciplinary approach. Hormonal status endocrinologist visual field orthoptist monitor tumor recurrence radiologist clinical observation neurosurgeon blood test biochemist